All right, welcome to the viral side of infectious disease, where things get tiny, sneaky, and honestly a little rude. Viruses are encapsulated genetic material, meaning they're basically DNA or RNA wrapped in a protein coat. That's it. No nucleus, no mitochondria, no ribosomes. No ambition, just vibes and bad intentions. And here's the key thing to remember. Viruses cannot replicate on their own. They are the ultimate freeloaders of the microbial world. If bacteria are roommates who don't do dishes, viruses are the ones who move in, eat your food, rearrange your furniture, and then destroy the house on their way out. From a histotechnology perspective, this matters because viral injury is not about the organism itself being visible. It's about what the host cell looks like after the virus hijacks it. Viruses enter a host cell, integrate their genetic material into the host DNA, or hijack the host machinery, and then force the cell to assemble new viral particles. Eventually, the cell either lyses, which is bursts, which is a dramatic exit, or survives but looks weird forever, which is where we come in. Viral infections are diagnosed by cellular changes, not by seeing the virus directly. Now let's talk about how viruses actually get into the body, because they are shockingly creative. Viruses can infect through aerosolized secretions, like influenza. Someone sneezes, you inhale, congratulations. Sexual contact, like HPV, HIV. Direct skin contact, a classic example of this would be chickenpox. Maternal fetal transmission, so HIV or hepatitis B. Insect vectors, so Zika or West Nile. And also contaminated food and water, where we would see things like hepatitis A or the polio virus. From a tissue perspective, this route of entry matters because it predicts which tissue gets hit first. Think of it like this. Respiratory viruses, we're going to see the epithelium of the airway get hit first. GI viruses, it's going to be the intestinal mucosa. Bloodborne viruses, we'd see the endothelium, liver, and immune cells get destroyed. Neurotropic viruses, the neurons in the glial cells. Some worthless but useful knowledge, viruses don't randomly infect tissues. They have tissue tropism, meaning they prefer specific cell types based on receptor availability. So basically, viruses are very picky eaters. As a histology takeaway, always ask yourself what tissue should look abnormal based on how this virus is said to enter the body. All right, viral infections are a little rude because the actual virus is actually too small to see on standard light microscopy. So in histology, we're not spotting the criminal, we're looking for the crime scene. That's why the second bullet matters. Some viruses make infected cells form inclusion bodies, which are little collections of viral proteins or particles and altered cell material that become visible in the nucleus and or cytoplasm. So think of inclusions like the virus leaving behind glitter. You may not see the person who brought it, but you will know they were there, and it will be everywhere, forever. Now look at the images. We have herpes simplex virus, HSV. The classic histology clue is large multinucleated cells. The cell looks like it couldn't commit to one nucleus, so it just picked several. You may also see amorphous pink material, or eosinophilic material, which represents condensed viral proteins and cellular debris. Cytomegalovirus, or CMV, the big clue is irregular enlarged nuclei with inclusions, most often described as that owl's eye look in other slides. On H&E, it's one of the most, oh, that patterns you'll learn. So what to look for on H&E? We have HSV, which is the herpes simplex virus. We're going to look for multinucleation, nuclear molding, crowded nuclei, and they can have eosinophilic material. So for CMV, we're going to look at for enlarged cell plus enlarged nucleus, and then inclusions, which often are going to have a halo. On the left image here, there are clusters of enlarged cells with multi-dark purple nuclei in the same cell. On the right image, you'll see there are cells with enlarged irregular nuclei and arrows pointing to suspicious inclusion-like changes. If you can't see the virus itself, what are we actually diagnosing on H&E? Well, the quick answer is the host response, or the cytopathic effect, and the inclusion bodies. Vaccines are I would prefer not to see this in the hospital section of today's content. This slide has given you examples of viral and bacterial diseases that have vaccines. So a quick translation, vaccines reduce the number of times we see severe inflammation, necrosis, scarring, and long-term organ damage caused by these infections. Some viral examples listed here, we have measles, rubella, varicella zoster, mumps, the rotavirus, hepatitis A, hepatitis B, HPV, and polio. Some bacterial examples listed here is whooping cough, pneumococcus, diphtheria, why you care as a histology connection is even if you never diagnose a vaccine, you absolutely diagnose the things vaccines help prevent. HPV prevention ties directly to reducing dysplasia and or carcinoma risk in tissues like cervix and oropharynx. Hepatitis B prevention helps reduce chronic liver injury patterns that can progress to cirrhosis and hepatocellular carcinoma. The measles or varicella prevention reduces severe systemic complications that can show up in multiple organ systems. Some worthless knowledge, but it's actually quite memorable. The Hib in the Hib vaccine is not the flu. It's the Haemophilus influenza type B, named back what people mistakenly thought it caused influenza. Names in medicine love to be historically messy. Here's the easiest way to remember this. Acute or transient infections. These are the viruses that show up, cause symptoms, and usually your immune system clears them. Like a guest who actually leaves when the party ends. So some examples listed here would be the measles, the mumps, poliovirus, West Nile virus, and viral hemorrhagic fever. Then there's latent infections. These are the viruses that move in quietly, stash their stuff in the basement, and then reappear when conditions are right, like the world's worst roommate. Examples listed here would be HSV, the varicella zoster virus, CMV, and EBV, which is the Epstein-Barr virus. Why latent matters to histology is latency is why some infections have those signature patterns that pop up later, especially in immunocompromised settings. So HSV or VZV can reactivate and cause recurrent lesions. Histology often shows viral cytopathic effects in the epithelium. The CMV often shows inclusions in the endothelial or stroma cells and can be a big deal in immunocompromised patients. The Epstein-Barr virus is tied to lymphoid processes in certain tumors, so it matters even when the primary infection seems self-limited. Category, just a quick check. Which category includes viruses that can hide out and reactivate later? Acute or latent? I am just assuming you all got that right. The answer is latent. Okay, now we'll take these categories and look at specific examples where histology gives us the biggest clues. Take a little bit of a breath. This is where we pivot from what viruses are to what viruses do to tissue, which is the part that actually matters to us in histology. When we say acute viral infection, we're talking about infections that hit hard, do their damage, and then either resolve or declare themselves loudly enough that everyone notices. These are not the sneaky long-term freeloaders we'll talk about later. These are the viruses that kick the door in, rearrange the furniture, and leave visible evidence behind in your slides. From a tissue perspective, acute viral infections tend to cause cell swelling, loss of normal architecture, inflammatory infiltrates, and necrosis or apoptosis, depending on the virus in the tissue. Think of acute viral infections like a flash flood. It comes quickly, disrupts everything in its path, and when it's over, you can tell exactly where the damage happened. As histotechnicians, our job isn't to diagnose measles clinically, it's to recognize when the tissue is screaming, "This was viral." Start with measles, an acute viral infection that is both incredibly contagious and incredibly dramatic at the tissue level. Clinically, measles look like a really bad cold that escalates into something much worse. Histologically, it's a master class in how viruses can hijack immune responses and cellular machinery. This virus spreads through respiratory droplets, which means it's efficient, disturbingly efficient. One infected person can expose nearly everyone in a room. Viruses don't need motivation, they just need opportunity. From a tissue standpoint, measles causes diffuse epithelial damage, marked immune activation, multinucleated cells in respiratory tissues, and yes, despite vaccines, measles remain one of the leading causes of vaccine-preventable illnesses and death worldwide. From a lab perspective, this means you will still see it, especially in lung tissue. If you ever wondered why measles slides are such good teaching examples, it's because this virus leaves fingerprints everywhere. This slide is histology gold, so let's slow down and enjoy it. First, antibody-mediated immunity protects against reinfection. That's why measles infection or vaccination usually equals lifelong immunity. Immunology for the win. Now, the stars of the show. The Koplik spots. These are ulcerated mucosal lesions in the oral cavity. Histologically, what you're seeing is necrosis, inflammatory exudate, and damaged epithelium. They're small, but they're diagnostic, the viral equivalent of a calling card. Then we have the Werthen-Finkelday cells. These are the histotechnicians remember forever. They are multinucleated giant cells with eosinophilic nuclear and cytoplasmic inclusion bodies. They are typically found in lung tissue and sputum. These cells form because measles causes cell fusion, basically forcing cells into an awkward multinucleated group project no one asked for. On H&E, these cells look oversized, crowded, and abnormal, which is exactly the point. Viruses don't politely rearrange cells, they distort them. If you see giant nucleated cells with inclusions in respiratory tissue, your brain should immediately whisper, viral. Next up is mumps, the virus best known for turning salivary glands into balloons. Mumps is an acute systemic viral infection, and its favorite tissue targets are the salivary glands, particularly the parotids. Histologically, what's happening here is not subtle. You'll have edema, inflammation, disquamination of glandular epithelial cells. These ducts swell, the acini lose organization, and inflammatory cells move in like they've been personally offended. This structural disruption explains the clinical pain and swelling. Tissue architecture matters, and when it's distorted, function follows. Mumps don't always stay put. It can spread to the central nervous system and become what we call mumps encephalitis. It can spread to the testes, which is also referred to as mumps orchitis, or it can spread to the ovaries and pancreas. From a histology standpoint, anytime a virus spreads systemically, expect multi-organ inflammatory changes, not just localized damage. Polio is one of the viruses that reminds us why vaccines are one of humanity's best ideas. Poliovirus is an acute systemic viral infection with a very wide range of outcomes, from mild, self-limited illness to irreversible paralysis. This is an enterovirus transmitted via the fecal-oral route, which explains why sanitation dramatically changed its spread. Histologically, polio is less about epithelial damage and more about neural destruction. The virus selectively targets motor neurons, particularly in the spinal cord. When those neurons are damaged or destroyed, muscles lose innervation, the muscle fibers atrophy, and then paralysis follows. The reason polio vaccines work so well is beautifully simple. Humans are the only host. Antibodies neutralize the virus effectively. The Salk, which is killed, and the Sabin, which is live attenuated, vaccines nearly eliminated this disease, which is why you may never see classic polio pathology in your career, but you must understand it. Because histology isn't just about what you see, it's about knowing why you're not seeing it anymore as well. Right. Let's talk about West Nile virus, the virus that reminds us mosquitoes are not just annoying, they are professionally dangerous. West Nile is an acute systemic viral infection, and from a histotech perspective, the key thing to remember is that most people, about 80%, are completely asymptomatic, which is honestly rude behavior for a virus. When symptoms do show up, they're pretty nonspecific at first. Fever, headache, fatigue, malaise, your classic, is this a virus or did I just sleep weird scenario? Now here's where histology matters. In rare cases, about 1 in 150, West Nile crosses into the central nervous system, leading to meningitis, encephalitis, or meningioencephalitis. What would that look like histologically? We'd see perivascular lymphocytic cuffing, microglial nodules, neuronal injury and loss, as well as inflammation centered around small vessels. Translation: the tissues look irritated, swollen, and very unhappy, like it's been hosting guests that overstayed their welcome. Some wordless but fun knowledge here on this slide are that birds are the main reservoir. So when birds start dying in clusters, epidemiologists start sweating. Histotechs? We just sharpen our microtome blades. All right, deep breath. This slide is intense visually, but we're going to keep it academic and histologic, not horror movie-like. So we have viral hemorrhagic fevers. Think Ebola, Marburg, the Lassa. These are all severe, life-threatening, multi-system diseases. The hallmark feature is damage to blood vessels. From a tissue standpoint, this is really about endothelial injury. Some histological highlights, we would see widespread vascular leakage, endothelial cell swelling and necrosis, interstitial hemorrhage, thrombocytopenia-related bleeding, and minimal inflammation early on, which is kind of counterintuitive. But this is important. The tissue doesn't look wildly inflamed at first. It looks structurally compromised. Blood is going places it absolutely should not be. As the disease progresses, we'll see shock, multi-organ failure, hepatic necrosis, adrenal hemorrhage. And the histotech pearl here is that these tissues are extremely fragile. Sectioning hemorrhagic organs is like cutting overripe peaches. Support and blade quality matter a lot. Zika is a great example of a virus that looks relatively mild in adults, but is devastating at the developmental level. Zika is transmitted primarily by Aedes aegypti mosquitoes, but also through sexual contact, blood transfusions, and vertical transmission. Most adults experience fever, arthralgia, conjunctivitis, and a macular papular rash. Histologically, pretty bland in adults, but in fetuses, it's a completely different story. Some key histological findings in congenital infections, we'd see microcephaly, reduced cortical thickness, neuronal loss, calcifications, and disrupted neuronal migration. The virus targets neural progenitor cells, basically sabotaging brain development at the blueprint stage. So, analogy time. Zika doesn't knock down the house, it deletes the architectural plans halfway through construction. Some worthless knowledge. The spike in reported cases in Brazil in 2015 is what really pushed Zika into global awareness and into pathology textbooks everywhere. Dengue is another flavivirus, also mosquito-borne and wildly common. 390 million cases per year. That's not a typo. Most cases are self-limited, but dengue earns its nickname break bone fever for a reason. Histologic features, there would be capillary leakage, endothelial dysfunction, bone marrow suppression, and thrombocytopenia. In severe dengue, aka dengue hemorrhagic fever, we'd see plasma leakage, hemorrhage, hepatic necrosis, and shock. Under the microscope, you'd see congested vessels, patchy hemorrhage, liver showing apoptotic hepatocytes, and minimal inflammatory infiltrate early. Again, notice the pattern. Viruses that cause hemorrhage often damage structure more than they provoke inflammation. A histology pro tip here, if everything looks washed out and leaky, it's not your staining, it's the disease. And finally, SARS-CoV-2, the virus that permanently changed the phrase emerging disease. COVID-19 primarily targets the respiratory system, but histologically it is a vascular and inflammatory disease. So we'd see lung histology highlights that we would see, are diffuse alveolar damage, or DAD, hyaline membrane formation, type 2 pneumocyte hyperplasia, and microthrombi in pulmonary vessels. There might also be some interstitial inflammation. This is why oxygenation fails, even when lungs don't look that bad radiographically. Beyond the cells, we'd see endothelial injury, microvascular thrombosis, and multi-system involvement, such as the heart, the kidney, or the brain. So analogy here is the COVID doesn't just clog the airways, it breaks the plumbing and shorts the wiring at the same time. The Histotech takeaway is that COVID taught pathology and histology labs a lot about biosafety, fixation protocols, and the importance of vascular pathology, and about how fast new diseases can become exam material. So before we move on, here's the big histology message from the last few slides. Viral infections often cause structural damage more than dramatic inflammation. Endothelial cells are frequent targets. Inclusion bodies, necrosis, syncytia, and vascular leakage are your visual clues. Not all dramatic clinical disease looks dramatic on H&E and vice versa. Or in histotech terms, if the tissue looks subtly wrong everywhere, trust your instincts. It probably is. Okay. Welcome to the viral equivalent of I didn't leave, I'm just hiding. Latent viral infections are infections where the virus never truly exits the building. Instead of being cleared by the immune system, the virus enters a dormant state inside host cells. Think of latency like a Netflix subscription you forgot to cancel. You're not actively watching it, nothing seems to be happening, but it's still there, waiting for the right moment to suddenly become very relevant again. During latency, there is minimal to no viral replication, and patients are often asymptomatic. But under conditions like stress, illness, immunosuppression, or aging, the virus can reactivate. From a histology standpoint, this explains why we sometimes see viral cytopathic effects in patients with no new exposure history. The virus didn't arrive yesterday. It's been camping out quietly for years. This concept is foundational for understanding recurrent lesions, unexpected inflammation, and why old infections still show up on slides long after the original exposure. Poster children for viral latency are the herpes simplex viruses, so HSV1 and HSV2. These two viruses are closely related genetically, but they differ serologically, meaning the immune system can tell them apart, which becomes important for diagnostics and epidemiology. Both viruses begin their infection the same way. They replicate in the skin or mucous membranes at the site of entry, typically the oropharynx or the genital region. This local replication causes vesicular lesions, which are essentially tiny fluid-filled blisters packed with virus. If you've ever wondered why herpes lesions look the way they do, that's viral replication plus epithelial cell damage in action. Here's what herpes viruses earn their reputation. After initial replication, they travel along sensory neurons to regional nerve ganglia. So, translation, the virus hijacks your nervous system like an Uber. It rides to the ganglion and then goes completely silent. From the lab side, this neural latency explains why lesions recur in the same location and why viral DNA can persist long term, even when patients feel perfectly fine. Now let's get to the part where you actually care about what this looks like under the microscope. Herpes simplex infections have a classic board favorite histological feature. It's called Caudray type A intranuclear inclusions. These appear as large pink to purple inclusions inside the nucleus of infected cells. They represent viral replication proteins and assembled virions, piling up in nuclear real estate they absolutely do not own. Histologically, the nucleus often looks enlarged with chromatin pushed to the edges. A look sometimes described as ground glass. A fun but useful trivia: once you've seen a true Caudray type A inclusion, you will never forget it. It's like recognizing someone who once borrowed money from you, instantly familiar and slightly irritating. Clinically, herpes infections range from annoying cold sores to decimated visceral disease and encephalitis, especially in neonates and immunocompromised patients. In histology, seeing these inclusions should immediately trigger the thought, this is herpes, until proven otherwise. Herpes simplex viruses don't present at just one disease. They're overachievers in the worst possible way. We have gingivostomatitis, typically caused by HSV1. It presents as painful vesicular lesions in the mouth and the tongue. This is most commonly seen in children, often during their first exposure. Herpetic whitlow involves painful vesicles on the fingers or palm. This is classically associated with infants and healthcare workers, which is why glove use is not optional. It's actually survival. Genital herpes is more often caused by HSV2, though HSV1 can also be responsible. These lesions ulcerate rapidly and are often more severe. A critical histology meets clinical point: neonates can acquire HSV2 during passage through the birth canal. This can result in devastating systemic infection. When correlating pathology reports with patient history, age, lesion location, and immune status matter. And herpes viruses are a perfect example of why. To wrap up herpes simplex, let's talk about why this virus deserves your respect. HSV1 is the leading infectious cause of corneal blindness in the United States. Recurrent reactivation leads to scarring that permanently alters vision. HSV1 is also the most common cause of fatal sporadic viral encephalitis in the U.S. This disease can progress rapidly and has a high mortality rate without prompt treatment. From a histology standpoint, herpes viruses beautifully demonstrate how viral behavior explains tissue appearance. Latency explains recurrence. Neural spread explains lesion location. Nuclear inclusions explain diagnosis. This is why we don't just memorize facts in this course, we learn the mechanisms. Because when you understand why something happens, the slide tells a story instead of just looking like pink and purple chaos. And yes, herpes viruses are forever, much like glitter, or group chats you can't escape. Let's talk about the verifiable booster virus, or VZV, the virus that absolutely refuses to leave your body once invited. VZV causes two very different diseases, depending on when it shows up in your life. The first infection causes chickenpox, which most people think of as itchy misery and calamine lotion. But histologically, it's much more interesting than that. VZV initially infects the mucous membranes in skin, spreads through the bloodstream, and then produces widespread vesicular skin lesions. These vesicles are filled with virus-infected epithelial cells. Now here's the important part, and this is where VZV starts acting like a bad house guest. After the acute infection resolves, VZV does not leave. Instead, it retreats into sensory neurons, particularly dorsal root ganglia, where it establishes latency. Histology Pearl here, you won't see latent VZV on routine H&E. No inclusions, no inflammation, just normal appearing neurons silently harboring virus. Worthless but memorable knowledge is the VZV spreads by respiratory aerosols, not just skin contact, which is why chickenpox spreads so efficiently in classrooms. Chickenpox lesions follow a classic progression, and this is one of those patterns exam writers love. You start with macules, which rapidly progress to vesicles, then rupture, crust over, and heal by regeneration, meaning no scarring in immunocompetent patients. This is an important distinction from diseases that cause dermal destruction, which do scar. Now contrast that with shingles. Shingles occurs when latent VZV reactivates, usually decades later, and travels down a single sensory nerve to the skin. This is why shingles lesions are unilateral, dermatomal, and extremely painful. They are not itchy, not mildly annoying. They are burning, stabbing, electric pain. Histology tie-in, the pain is neurogenic due to viral damage and inflammation of sensory neurons, not just skin involvement. A clinical pearl here is that shingles can be fatal in older or immunocompromised patients, which is why the shingles vaccine is strongly recommended for people over the age of 60. This slide is a fan favorite, and for good reason. Shingles follow dermatomes, which are areas of skin supplied by individual spinal nerves. Virus reactivates in one dorsal root ganglion and travels outward. It does not cross the midline. That's why shingles looks like someone drew a rash with a ruler and refused to cross the center. So think unilateral dermatomal rash is going to equal shingles until proven otherwise. Okay. Histologically, shingles lesions resemble chickenpox. You'll have ballooning degeneration of the keratinocytes, there's vesicle formation, and inflammatory infiltrates. But the clinical difference is the nerve involvement, which explains why patients often describe pain before the rash appears. Some worthless knowledge here are that patients sometimes think they pulled a muscle days before the rash shows up. That's actually the virus warming up the nerve. Now let's move on to the cytomegalovirus, or CMV, the herpesvirus with the most dramatic histology flex. CMV is a beta group herpes virus, and in healthy adults, it often causes no symptoms at all or a mono-like illness. But in neonates and in compromised patients, CMV can cause devastating systemic infections. And here's where histology steals the show. CMV infected cells become massively enlarged, both the cell wall and the nucleus, a feature called cytomegaly. Inside the nucleus, you'll see a large basophilic inclusion surrounded by a clear halo. This creates the famous owl's eye appearance. If you see giant cells plus intranuclear inclusion and a clear halo, the answer is always going to be CMV. Pathologists love CMV because it announces itself loudly, not subtly whatsoever. Finally, let's end with the Epstein-Barr virus, the virus that made kissing suspicious in high school. EBV causes infectious mononucleosis, which is a benign, self-limited lymphoproliferative disorder. Transmission is through saliva, which is why mono earned the nickname the kissing disease. But EBV is more than just mono. It infects B lymphocytes, driving them into proliferation. And while the immune system usually keeps this under control, EBV is associated with several malignancies, including Hodgkin's lymphoma, Burkitt's lymphoma, and nasopharyngeal carcinoma. Histology tie-in, is that in mono, you don't actually see EBV infected B cells easily. What you do see are reactive CD8 positive T cells responding to them, appearing as atypical lymphocytes and blood smears. So CMV, think of owl's eye inclusions. And some worthless knowledge here is that EBV can persist for life, meaning most adults are walking around with it completely asymptomatic. Okay, so slide 25 told us what EBV does clinically. This slide answers the question Histotech students always ask. Why do the blood smears look like that? Here's the key concept. The Epstein-Barr virus infects B cells. The cells we see in the blood are not infected B cells. The atypical cells you're seeing are actually, again, the reactive CD8 positive T lymphocytes that are responding to the EBV infected B cells. So a histology focus here would be these T cells appear larger than normal lymphocytes with abundant deeply basophilic cytoplasm. They're often hugging or scalloping around nearby red blood cells. If it looks like the lymphocyte is invading the personal space of red blood cells, congratulations, you're probably looking at a monocell. EBV is the problem tenant, the B cell is the apartment, and the T cells are the angry neighbors showing up to deal with it. So mono, think of reactive lymphocytosis, not leukemia. Big scary lymphocytes do not mean cancer in this context, okay? That's important to remember. So now we're shifting gears to HIV/AIDS, which is still one of the most significant viral diseases worldwide. HIV primarily targets CD4 positive T lymphocytes, which are basically the immune system's project managers. When those disappear, nothing gets coordinated. Clinical manifestations include decreased CD4 counts, wasting, lymphoidenopathy, opportunistic infections, neurologic involvement, including dementia, and then malignancies like Kaposi sarcoma and Burkitt lymphoma. So for analogy time, because I know how much you all love those, think of HIV like firing the entire management team in a hospital and then wondering why chaos breaks out in every department. A histology focus, there is no single diagnostic histologic lesion for HIV itself. Instead, we recognize it by the opportunistic infections and tumors that show up once immunity collapses. Now we're shifting from viruses to fungal infections, which behave very differently in tissue. And histologically, fungi are way more visible than viruses. A mycotic infection simply means an infection caused by a fungus. Think of fungi as the opportunists with a growth problem. They're often already hanging out on or in us, just waiting for the right conditions. The most common fungal infection you'll ever hear about or see in practice is Candidiasis, caused by Candida albicans. This organism normally lives on the skin, in the oral cavity, the GI tract, and the vagina. So yes, it's already a tenant. Problems happen when the balance is disrupted. Antibiotics, diabetes, immunosuppression, or extremes of age allow Candida to overgrow, turning from a quiet roommate into the one neighbor who plays music at 3 a.m. Clinically, Candidiasis shows up as oral thrush, those white curd-like plaques, or diaper rash in infants, or vaginal yeast infections. Histologically, Candida is fun because you can actually see it. Budding yeast, pseudohyphae involving epithelium, and then special stains like PAS or GMS light these organisms up beautifully. Fungi absolutely love silver stains. Histology pro tip, if it stains bright pink with PAS and looks like branching structures in epithelium, your brain should immediately whisper, fungus did this. Some worthless but memorable knowledge, Candida albicans means whitish white, which is fitting because it literally announces itself as white plaques. This slide introduces systemic and endemic fungal infections, which are less common but far more serious, especially in immunocompromised patients. Unlike Candida, these fungi are usually acquired from the environment, often through inhalation of spores. Histoplasmosis is a classic example. It's associated with bird and bat droppings, especially in the Ohio and Mississippi River valleys. In most healthy people, it looks like a mild flu, but in others, it can decimate to the lungs, liver, lymph nodes, and even retina. Coccidiomycosis, also known as valley fever, is found in dry, desert regions, especially the Southwest. It often causes flu-like symptoms, but chronic cases can lead to meningitis or arthritis. This fungus thrives in dust, so construction zones are basically its favorite vacation spot. Blastomycosis causes pneumonia-like illness with fever, muscle pain, and headaches. Histologically, its yeast forms are thick-walled and broad-based budding, which is a board favorite phrase. Cryptococcus is especially important in HIV/AIDS patients. It can be asymptomatic in the lungs, but has a dangerous tendency to spread to the central nervous system, causing meningitis. The histology takeaway: many of these fungi are identified by the yeast size and shape, their budding patterns, and the presence of a capsule. Hello, Cryptococcus. So think of endemic fungi like regional accents. If you know where the patient has been geographically, diagnosis suddenly gets much easier. This slide is essentially your immune system has called out sick lineup. Opportunistic infections occur when the host defenses are compromised, and the organisms listed here are incredibly good at taking advantage of that. Let's break this down by category. Fungal opportunists include Candida, we just met this troublemaker, Aspergillus, classic septae hyphae with acute angle branching, and then we have the Rhizopus, which is broad ribbon-like non-septate hyphae that look chaotic. Then we have Pneumocystis jirovecii, which is especially important in AIDS. There's Cryptococcus neoformans, which is an encapsulated yeast with a halo you cannot miss. If you ever see a clear halo around a yeast cell, think Cryptococcus and reach for the mucicarmine. Viral opportunists include the cytomegalovirus, HIV itself. Bacterial opportunists are the Mycobacterium avium complex. The protozoal opportunists are Toxoplasma gondii, Cryptosporidium. So big picture takeaway is that in immunocompromised patients, the question is not what could cause this, it's what isn't allowed to cause this. So histology saves lives here because identifying the organism on tissue often drives therapy faster than cultures ever could. All right, welcome to the world of helminths, or as I like to call them, the freeloaders of the infection world. Helminths are parasitic worms, and they come in two major flavors, so roundworms or flatworms, which typically include flukes and tapeworms. Unlike bacteria or viruses, these organisms are huge, at least on a cellular scale, and they're not subtle. They survive by stealing nutrients directly from their host, which is honestly bold behavior. From a diagnostic standpoint, helminths are often identified by eggs, larvae, or actual worm fragments in fecal material. Yes, sometimes the diagnosis is literally, there's a worm. Most infections occur through contaminated food or water, and once inside, these parasites set up shop in the GI tract, although some species migrate to muscle, lungs, liver, or even the brain. A histology focus is that helminths are usually too large to see whole and tissue sections. So what we often identify are eggs, larvae, and surrounding inflammation, fibrosis, or eosinophils, which are a big clue. So analogy time here, think of helminths as uninvited house guests who eat all your food, break things, and refuse to leave. And your immune system is stuck cleaning up the mess. This slide looks overwhelming, and that's okay. You are not expected to memorize this entire table. What I do want you to focus on is the pattern recognition. So helminths cause disease based on how they enter the body, where they migrate, and where they settle. For example, schistosoma enters through the skin via contaminated water and loves the liver, bladder, and intestines. Trichinella spiralis comes from undercooked pork and ends up encysted in skeletal muscle. Taenia solum larvae can migrate to the brain, causing seizures. And so a histology focus is on tissue sections. Helminth infections often show encysted larvae, thick-walled eggs, granulomatous inflammation, and heavy eosinophilic infiltrates. That muscle image on the slide, those are Trichinella larvae encysted in skeletal muscle. And once you've seen it, you'll never forget it. Worthless but helpful memory trick is if a parasite came from pork, think muscle or brain. If it came from water, think liver or bladder. If it came from fecal oral exposure, think intestine. Now let's talk about something that breaks every rule you've learned so far. Prion diseases are caused by misfolded proteins, not bacteria, not viruses, not fungi, just proteins that have gone rogue. A prion protein forces normal proteins to misfold, leading to accumulation, neuronal damage, and rapid neurodegeneration. The classic example is the Creutzfeldt-Jakob disease, or CJD, historically linked to ingestion of infected beef products. This disease is rare, always fatal, and horrifyingly fast. Histology focus, CJD produces spongiform encephalopathy, meaning there will be vacuoles that form in the brain tissue. The tissue looks like a sponge. There is no inflammatory response. The last part is key. The immune system doesn't know what to do because there's no invader. Analogy time. Prions are like one badly folded sweater in your drawer that somehow forces every other sweater to fold itself wrong too. Prions resist heat, they resist radiation, they resist disinfectants. Basically, they are the horror movie villains of microbiology. And with that, you've officially made it through one of the most content-dense sections of the course. You've seen how infections can be microscopic or massive. Damage can come from the organism itself or the immune response. Histology gives us clues when cultures and labs fall short. Every image in this lecture was included for educational purposes, and if something raised questions or mild concern, that's normal. Don't hesitate to reach out, email me, stop in at office hours, or ask questions early rather than letting confusion snowball. If you remember nothing else from this unit, remember this. Pattern recognition saves lives. You did great work here. Take a breath, review the images, and we'll build on this foundation later. Thanks.